with that, we move on to the next session. Is semaglutide semaglutide in metabolic liver disease and emerging evidences in MASH. May I please invite our speaker for this topic, Dr. N. Arun, who is a gastroenterologist from Chennai. For the panel discussion, may I please invite Dr. K. Prem Kumar as the chairperson, please. And the panelists, Dr. Bharanidharan, please, diabetologist from Chennai. Dr. Joymon, again a gastroenterologist. Dr. Vamsi Mohan, sir. And Dr. L. Meenakshi Sundaram, sir, please.
Respected professors, senior consultants, and dear friends, it's really a great pleasure for me to be here. And I would like to thank Team MSN who gave me an opportunity. And today we all gathered here to explore one molecule beyond the boundaries. It's nothing but your semaglutide, as you are well aware, and the role in various specialities. And today and my role to talk on liver, the role of semaglutide. First thing is, what do you mean by fatty liver? In case if the patient, so we'll be coming across with multiple scenarios in a routine OP practice with evidence of fatty liver. How frequently in Indian population we are going to give importance to that in ultrasound when you are going to check? It's still a questionable issue. So we have been coming across with various patients, but are we giving importance to all the patients? No. So how are you going to sort out that? And once if the patient is going to land up with evidence of fatty liver, what is the semiology of event to get progress for further liver complications and other things? That's very important. And how are you going to clinically recognize your presentation, which means the patient is going to have fatty liver, followed by the patient may have evidence of your metabolic associated steatohepatitis-like presentation, and then the fibrotic changes, your cirrhotic changes to get progress with evidence what's called as a liver cancer, nothing but your hepatocellular carcinoma. See how the events is going to get progress, what are the various pathophysiological concepts, how are you going to recognize the clinical markers, and once you're going to diagnose it, how are you going to tackle, how are you going to manage. This is all the various area of disclosure for me today. So once, if the patient is having evidence of fatty liver, very important scenario, the fatty liver disease is always a diagnosis of exclusion. Don't think that every patient in the background of obesity doesn't mean that it's going to have fatty liver. So first thing is metabolic syndrome. As you all know, your 5 major components, your BMI, your obesity parameters, along with evidence of your dyslipidemia, your sugar levels and hypertension. All these pictures, you need to look into that to categorize the patient whether he is fitting into the criteria for metabolic syndrome. That's number one. Once a patient is going to have evidence of metabolic syndrome, next to that, your basic surveillance. How are you going to recognize? More than 5% of fat accumulation, we are going to get document. If the patient is going to have these findings, there are by ultrasound, you are going to do your MRI, PDFF, your magnetic resonance, proton density diffusion fraction, all those things you can see. But once if you are going to recognize with this kind of presentation, so how the events is going to get evaluated. Next to that, your metabolic associated steatohepatitis, in which we are going to do a histopathological examination to the liver, followed by you can able to diagnose your ballooning degeneration, inflammatory cascading hepatocytes is going to get taken. In Indian scenario, it's very problematic because are we going to do this MASH assessment for all the patients? No, because there are so many markers are there, non-invasive markers and all those things are there to diagnose. In global as well as epidemiology, so to consider about alcoholic liver disease in Indian scenario, we all well aware that. But alcohol, apart from alcohol, the next common scenario will be your fatty liver disease. In global population, almost 30 to 50 to 60% of the population will be in the range of fatty liver. In Indian population, almost around 30 to 40% will be having global population. That too in urban scenarios like centers like Chennai and Delhi will be in range of 50 to 60% of the population. So every 1 in 3 patients will be having evidence of fatty liver, so you need to be very cautious to assess. So this is what the basic epidemiology, and how are you going to recognize that, the basic pathophysiological concept. Very important, we need to target on 4 major molecules. When you're going to address the pathophysiology is mainly based upon your insulin resistance. Once the insulin resistance is going to get checked on, followed by your de novo lipogenesis, the mitochondrial dysfunction, beta oxidation, all these things which is going to get involved, followed by your various inflammatory cascade of cytokines which is going to get released, and then the liver injury, your metabolic associated steatohepatitis or fibrotic progression because of your collagen deposition, all those things, along with the patient tends to go for evidence of cirrhosis. In cirrhosis, two major picture. It could be a compensated cirrhosis or decompensation. Decompensation is nothing but if the patient is having huge ascites in the background of GA bleed and other things, in hepatic NCAF and other things. But decompensation means you are going to do a fibroscan assessment, which means the fibrotic changes, if it is going to be more than F4, which means the patient is going for compensated, but still the events not much progress. The patient will be remain stable. So that's what the compensation is still going on. So in order to categorize all these things, the basic pathophysiology. Why? What is the problematic thing which is happening? One thing, if you're going to do a diet and lifestyle, whenever you're going to do a diet and lifestyle, it's one of the most categoric driver to control your fatty liver. But are we going to maintain that? Why the newer molecules in pipeline is being considered nowadays? Because the diet and lifestyle alone will not be having very significant impact, around 5 to 10% of the population. And you should remember that metabolic associated steatohepatitis is not a component only based upon your diet and lifestyle. Your hormonal, metabolic, inflammatory, fibrotic, all the cascades which is going to get involved. Based upon that, this entire event is going to get problem. So is it possible to stop the area of insult in each and every parameter? So it's still a difficult task with your diet and lifestyle modification alone. But the problem with your molecules, even with the best of molecules, what are the things, your SEMA, your TESA, the pipeline molecule like your reticular, all those things, when you're going to consider, still the evidence of fibrotic regression will be a questionable issue when you're going to use the various anti-obesity molecules for targeting the patient with your MASH. And as you all know that right from 2025 onwards, initially the one proven molecule will be a resmetirom. From 2024 for evidence of MASH, FDA been approved, your THR-beta agonist. Apart from that, the now newer molecule like your semaglutide being considered, but various papers are being there. FDA is still approved. Apart from newer molecules like TESA, the FDA approval is still going on, not major considerations. But very importantly, the pathophysiology already you should remember that. This is the semiology of event, the fatty liver, fibrotic, cirrhotic, hepatocellular. Once a patient is going to land up 30 to 40%, and every 1 in 7 years there might be a worsening of cascades. The patient may go evidence of fibrotic changes, cirrhotic changes, liver cancer. So we need to stop the insult. That might be a trigger hypothesis. One may be a multi-triggered. It might be a triple. So first initially double-hit hypothesis concept came. After that the triple-hit hypothesis concept came. Now multi-hit hypothesis the concept has been driven, will look for, because there might not be even one factor. It might be a genetic alteration. For example, your PNPLA and your palatin peptide, your MBOT mutation. So many other genetic mutation factors are there to look for this, and phenotypic variation. That's why the metabolomics has been taking a significant role nowadays to target. Even your microRNA pathway has been taking a significant role. Your microbiota has been taking a significant role for to consider this pathophysiological cascade. It's still a major difficult area to analyze. Basic thing is the 5 major area: your insulin resistance, followed by your de novo lipogenesis, and your inflammatory, your fibrotic cascade, and all those things based upon the various markers which is going to get released, followed by the patient is going to land up with further progression. As we all know, the metabolic syndrome, obesity, type 2 diabetes, all these things, your dyslipidemia in the background will be having a significant. Right now in pediatric population, there may be evidence of more and more worsening of population as of now because of the childhood sedentary activity, more screen time. Even in pediatric, the evidence of NAFLD and MASLD has been taken over into account. But very importantly, what is the terminology? Metabolic associated steatotic liver disease has been taken over. Initially, it has been NAFLD. Why it has been removed there? Because non-alcoholic, it is very difficult to ascertain. Because most of the patient will be taking minimal amount of alcohol, but it's still a difficult task whether the patient is having evidence of metabolic dysfunction alone, or it might be a coexisting alcohol. There is a terminology what is called as metabolic associated. That's called MET-ALD. If the patient is going to take alcohol more than 30 to 40 grams per day, which means the MET-ALD definition is going to there, which means metabolic associated alcohol liver disease. Apart from that, metabolic associated steatotic liver disease, in which the alcohol component will be slightly there, still over lower line. So this is what the differentiating cascade for all those things. So you should know the basic definition how you're going to approach, and once a patient is going for this kind of MASH progression, As we are well aware, your diet and lifestyle, physical activity, exercise, apart from that, minimum exercise duration should be at least 150 to 300 minutes per week. Apart from diet, you should take care of your diet pattern, like your high fat diet definitely supposed to be reduced, high carbs definitely be restricted, and physical activity is supposed to be enhanced. This is what the basic things. But with all these things, still the fibrotic regression, the liver compensation, worsening of events to get regress will be slightly in the lower line. So only with diet and lifestyle we couldn't able to maintain that, and sustainability of diet and lifestyle is still a questionable issue in Indian population. So that's why, so apart from various other trigger factors we are going to address, so the pharmacological management has been taken over. Pharmacological management, remember these four major points. Any molecule which is going to act on hepatic inflammatory cascade, liver fat accumulation, antifibrotic, and apart from that, this is what the basic outline. So antifibrotic fat, huge list of molecules are there. To think about your semaglutide, very importantly, start the patient. What are the various indications? You are going to do a scoring system, what is called as fibroscan. In that fibroscan, you are going to look for two major parameters. One is your CAP and another one is KPA, which means your fibrotic changes. If the patient KPA, if it is going to be more than 12, which means the patient is having evidence of fibrotic and cirrhotic changes. If the CAP scoring less than 240, which means your controlled attenuated parameter, which means 240, which means the patient's steatosis is not well marked. If it is going to be more than 290, the steatosis has been well established. So what are you going to do? You need to start the patient on therapy. We can think about huge list of molecules starting from your resmetirom, soraglitazole, your semaglutide. Semaglutide, what is the role? If in the background of obesity, if your BMI if it is in the higher side, in the background of fibrosis, in the background of metabolic associated significant trials like Synergy, there is a trial in which it has been proven that 72 weeks of therapy, the primary endpoint. So once you are going to start the patient on semaglutide, we need to look for the primary endpoint in which the steatosis has to improve along with fibrosis should not get worsened. The secondary endpoint will be the fibrosis should improve with steatosis not supposed to get worsened. So over a duration of 240 weeks, they have been assessed, in which they have been able to identify that with your semaglutide, with dose escalation therapy, you can able to consider that. But very importantly, when you are going to use a semaglutide, there has already been previous speakers been mentioned about the huge list of cascade of adverse events, but how are you going to document that? Regarding the GI, gastric emptying pathway, all those things will be going to get involved. GI symptoms, your hepatic, your gallstone risk, your apart from your optic neuropathic changes based upon your posterior ciliary artery, which is going to get involved, and pancreatitis, even then less than 0.5% of the patient, and your contraindication like MCT, in which the C cells of the thyroid which is going to get involved, and apart from that, your medullary endocrine type 2. These are all the various cautious contraindications as well as adverse events you need to address. But if you want to titrate, start from 0.5, 0.25, 0.5, 1, 1.7, 2.4 dose escalation therapy. You can consider every 4 weekly subcutaneous when you are going to take. But in order to prevent the GA events worsening, because GA symptoms 60 to 70% of the population. I came across very recently with a patient who took semaglutide for a duration and then he had GA symptoms, followed by he stopped the molecule. So this is one area we should not forget that. So always frequent small meal, avoid high fatty food, encourage the patient more physical activity, diet, lifestyle, and then slowly escalate the dose for not to be in a hurry. So always slow escalation will be more potential. If you're going to do that, definitely around 60 to 70% of the population will be having significant response to the therapy to consider. So before concluding, very importantly, diet, lifestyle, physical activity, all this picture will be there, and you list once a patient is going for fibrotic changes, stage 3, F3 and F4, which means the patient deserves tirzepatide in the background, because weight reduction definitely will be in the higher side, fibrotic regression will be in the higher side. And newer molecules still are there. Before concluding, diet, exercising, assess the patient as a whole, look for evidence of steatohepatitis, histologically proven, you can definitely consider this molecule, but look for the serial assessment, because hepatic manifestation is still a targeted area to get assessed, which means one molecule alone will not be sufficient. You need to categorize on each and every parameter to address this clinical presentation of metabolic associated steatotic liver disease in a significant way. With this, I'm happy to rest. Thank you for your patient visit.
A very good and lucid presentation from Dr. Arun. MASLD is becoming a public health disease because of increasing rates of type 2 diabetes mellitus and obesity in India, and also the adolescent also children and adults are also having a steatotic liver disease. So that also will cause increase in the prevalence in coming years. So there need to be a solution for this. So many drugs are in pipeline for that. One such drug is this GLP-1 agonist and dual GLP bar GIP agonist. So that is in pipeline. So the DCJ, whether the approval is given by DCJ for MASH usage. So US FDA has approved it for usage in MASH. But DCJ is yet to approve the drug for
FDA has approved.
FDA has approved for
August 25 there.
FDA has approved.
August 25 they approved.
FDA has been approved for evidence of MASH prevention proposition.
So only is yet to get approval from DCJ for usage for MASH in India.
Yes.
Okay. Keeping it that in mind, so many trials they have done in the other population. Whether any trials are being done in Indian population for MASH.
So as of now, mainly we have been looking into the synergy. Even in Indian population also, we have been looking for various trials like your outflow trials and all being going on. But still, we need more and more papers to document the beneficial role, whether it is still existing or not.
Arun, combination of GLP-1 receptor plus glucagon receptor agonist.
Yes, sir.
They have got a more effect for the hepatic fat reduction.
Sure, sir.
Namely, GOTA-2 tried and MASH-2 tried. These drugs are available now.
Yes.
They have run a trial and they have found out that instead of semaglutide, this has got a more effect for reducing the hepatic fat content.
That is what they have been mentioned, sir. Starting from 1 milligram, 4, 8 and 12 milligrams of dose escalation with your retarded today, they have been having significant. But these kind of trials have been having proven role up to 48 weeks of therapy. But this trial, we have been having evidence up to 72 to 240 weeks. But the problem is, we have tirzepatide and other molecules when we are going to compare, there is only 4 years of data have been there. But semaglutide, there is more than 10 years of data have been there. Regarding the hepatic, other than hepatic, regarding other safety profile, your cardiovascular, to prevent the cardiovascular, your nephro and other things, we need more and more paper to document the beneficial role of tirza when compared to sema. All the areas will be still well addressed with sema. That's why still sema scores high, even though the fibrotic regulation is a challenging issue when we are going to consider. Semaglutide is still scoring high when you are going to tackle with this kind of presentation.
So another product which is now trial is going on. Fibroblast growth factor 21.
Yes, FGF.
That is a speculated fibroblast growth factor agonist.
Yes.
That they have tried. That has got a major effect on the hepatic lipid metabolism,
Yes.
and that
Stillates.
reduces hepatic fat also.
Hello, Dr. Aruna. It's a very elegant presentation.
Thank you.
I am a diabetologist. I just want to know from your end that because most of the time we see the patients present the fatty liver. So how to approach in the practice, and what is the role about where you are placing the saraglitazar?
Saraglitazar, sir, it's a fantastic molecule to be considered, but it's not been properly recommended in the background of obesity population. So very proven trial in the background of lean naphthalene, which means the patient is having evidence of lean MASLD population. Lean AST-ALT ratio, which is going to be in the higher side, worsening of parameter, definitely the best line of molecule will be your saraglitazar. Diabetic dyslipidemic status, the best line of molecule still will be your saraglitazar, because it will be having two major areas of mechanism. One is your PPA, alpha as well as gamma. So if we are going to target this, we will be having a liver effect as well as a systemic effect. So liver effect will be having a predominantly the lipogenesis, all these things, and your systemic effect will be having the fatty acid oxidation. All these things will be having significant potential role with your saraglitazar. So saraglitazar, two major indication, but even then in this kind of background we can consider, but the fibrotic regression and other things will not be having significant potential role like what is happening with the semaglutide, which has almost proven to be alone 50 to 60% of the population showed that the evidence of semaglutide being respond to the therapy.
Thank you. So another thing is any experience on resmetirom in India actually, because I think it is not coming to India, but sometimes you can just get it because since you work in a institute
resmetirom is well proven, sir, because it's been as of now the only approved molecule apart from your semaglutide from 2024 onwards, your resmetirom, which is predominantly based upon your THR agonist, which means the thyroid sensing cascade, which will be equally potent with your liver sensing receptors. That's why the mechanism. And resmetirom, as we having a strong antioxidant potency, that's why at the dose of almost around 100 milligrams, we can consider the patient with the duration of therapy. But Apart from that, the antifibrotic effect is still a questionable issue with your resmetirom. Even then, the papers are there to support with F2 and F3 fibrosis, but still semaglutide scores high when in this kind of presentation with obesity.
So one more thing is actually the semaglutide is not just preventing the fibrosis, because actually it works only in the indirect pathway. I don't think so. The only direct pathway is the resmetirom. So what will be the future actually? Whether the semaglutide have any direct pathway in just addressing the MASH or?
Yes, sir. Semaglutide in hepatic benefits, there will be having evidence of direct pathway. Even though there its major area of interaction will be in the 5 major, your liver, your pancreas, your adipocytes. Apart from that, in the CNS signaling and your gastric signaling, all these 5 major areas to represent, there might be having some minimal direct effects in the liver in order to prevent the lipid peroxidation, mitochondrial dysfunction. There might be shown some papers or trials that showed some minimal direct effects is still going on with the semaglutide.
The direct effects, as you mentioned, Bharnidharan, it works on the EPAC receptors, semaglutide. And EPAC is important for liver fibrosis. When you inhibit that, the fibrosis comes down. That's one of the direct methods.
So actually there is no GLP-1 receptors in the liver.
No, that's right. It works on the EPAC receptors. EPAC. That is also present in the beta cell.
Oh. Only that is an indirect thing, right?
So liver is studded with glucagon receptors. And one of the major side effects of resmetirom, I have tried so many patients, they all complain of diarrhea. So they discontinue the drug because of the diarrhea.
Even with your semaglutide, there are papers to document around 30 to 40%, even then we'll be having evidence of diarrhea. So GI events will be very common scenario in whatever the molecules we are going to choose. But addressing the presentation as a whole, we need to choose the best line of therapy to address this kind of issue. But serial follow-up matters a lot. The assessment, the fibrotic scoring, the clinical picture, histological severity, whether the patient is responding. It's still very challenging task in Indian scenario to manage such kind of population.
I have 2 questions. One is, what do you think will be the role in a non-diabetic, non-obese NASH of semaglutide on the NASH? Who is non-diabetic?
Non-diabetic, non-obese, MASH alone with evidence of no major worsening of fibrosis, no major role to be considered, sir. In the background of diabetic, obese, in the background of worsening of changes, we can consider. Apart from that, non-diabetic, non-obese, still the other molecules we can able to consider rather than this alone to be. But we can, there are papers to prove that there might be having a minimal potential role, but it has been classically established in the background of diabetic, obesity, in the background of your F2, F3, not in F3, F4.
And next is, they tell that once we reduce the dose or when we stop the dose, there will be a rebound of the obesity.
Yes.
So how can it will be effective on NASH?
That's what, sir. Once if your patient is going to stop the patient on therapy, there might be having worsening of fibrosis, regression, all the picture, whatever the thing which has been there in the previous scale will be having a possibility to escalate further. So, drug escalation, drug reduction will not be a major thing. We should be very cautious when you are going to do a reduction of dose. Usually, we need to consider the patient at least for a duration of, there are papers to look at least for 270 weeks of consideration being there to consider. Thank you very much.
Thank you, Dr. Arun, and thank you to the chairperson and panelists for this good discussion. Our next session is on, is semaglutide best in reducing cardiovascular or renal risk? I'll invite our next speaker, Dr. Ranjani Muthu, who is a nephrologist from Chennai, for this talk.